My name is Mitch Scott, and I want to thank Abbott for inviting myself, and on behalf of the other speakers, thank Agim and Gillian for asking us to do these presentations. Today, I'm going to start off talking about a study that we did and looked at patient outcomes following implementation of a new troponin I assay that had much better performance characteristics. Nick Mills from the University of Edinburgh is going to talk about rapid rule-out using sensitive troponin methods, and then Peter McCullough from Baylor will be talking about the use of galectin in heart failure. So with that, I would like to begin my presentation, and I'm actually going to take the approach of a laboratory director. I mean, one of the things that we stress in this field is the impact of lab tests on patient outcome, how improving laboratory testing can improve patient care, proper therapeutics, et cetera. So I'm actually going to start off talking about things other than troponin, just briefly, to give you some examples of the types of things that as a laboratory director we think about. I have to put this up there. And my disclosures, you can see where I get some research support and companies that I serve as a consultant for. So what I want you to think about, and we'll end with troponin I as an example of a test to look at, but how do you identify those tests that are worth investigating for the impact of their performance on outcomes? Well, think about what type of outcomes we want to look at. Are they measurable? Are they too subjective that it probably isn't worth looking at? And then finally, the real purpose of the talk today is the impact of an improved analytic performance of troponin on patient outcomes. So which test should we study? I mean, in my laboratory, we do hundreds of tests. And quite frankly, most of them have very similar analytic performance between manufacturers, and many will say they've actually been commoditized. But some do not. And which ones do we want to think about? So, tests where the diagnosis is based on the test result. Result of a test is a decision in guideline recommended algorithms. Many guidelines out there, and the result of a laboratory test is a branch point. Those are the types of tests that we might want to look at to see how performance affects patient outcomes when the guidelines separate at the point of the test result. What outcomes do we want to examine? First, think of things that are relatively easy to pick off. We can get ICD-9 codes on discharge. We can get billing codes for procedures. These are all in the electronic health record or in the billing records. And finally, let's not look at things that are really rare events, because when you get into really rare events, the N and the power that you need can make a study virtually impossible to do. So here's an example of a test that's probably not worth examining. Sodium, okay? If you look, this is taken from CAP participant summary data, and you'll see that the mean value in each row here is a different sodium method. They're all within 2 or so of each other. Imprecision's about the same. Now here's one that has imprecision of 4% versus less than 2 for all the rest. What would you look at with sodium? Changes in IV fluid administration, whether or not the patient was edematous, inconsistent results from one to the other. Well, sodium's a pretty well-performing method. Probably not worth looking at sodiums. Okay, how about some tests that may be worth looking at? But ferritin? So why ferritin? There are KDOQI, Kidney Disease Outcome Quality Initiative, guidelines on managing patients with chronic kidney disease, and these cut points affect how much iron you give, IV iron, and whether or not you give EPO. Well, we did a study. I'm not going to show you the results, but there's tremendous between method bias. And we published this paper in Kidney International in 2009, and depending on which method you use is going to impact how much iron is given, how much EPO is given, and it's going to impact the hematocrit of the patients on chronic kidney disease. How about PTH? Again, KDOQI guidelines. This guideline is only 201 pages long, but many of the algorithms are based upon the PTH result. And these are the cut points. They were all established in the 1990s when there was a single intact PTH assay on the market. And you see various cut points. When you get above 800, you start talking about parathyroidectomies. Well, many PTH assays were introduced after 2000, and they're all over the map. And there's several studies, none of which were from my lab, but which PTH assay you used impacted how much vitamin D was given. This became the most common PTH method during the 2000s, and the number of parathyroidectomies went up in the country. So these are the types of tests you might want to look at for the impact on patient treatment, patient outcomes. All right. What about the impact of improved sensitivity of cardiac troponins? Everybody's aware that we've gone from insensitive methods when troponin was first introduced in the late 1990s to everywhere in the world except the US, high sensitivity troponin assays. I'm sure many of you are familiar with this study, but improving sensitivity gave you a much better ROC curve. And what I just want to spend a little time on this. The blue line here is the contemporary Abbott troponin I, the method that is currently available in the US. You see the Roche high sensitivity troponin T in green, Roche troponin I in orange, and in the light blue is the standard assay, and at that time what they were doing was the Roche troponin T that's available today in the US. And as analytic sensitivity of the methods improve, the area under the curve for diagnosis of MI, and this was a cohort of ED patients, improved tremendously. This is a study that we did, and this is one of many studies showing that the presence of low levels of troponin in patients is bad. There's many studies showing this, that the presence of any troponin with a high sensitivity assay predicts poor outcomes. So I've already basically said this. You increase the ability to detect MI and ACS, predicts long and short-term risk, but it does reduce specificity. And I have in quotes here false positives. You can see this in heart failure, cardiomyopathy, pericarditis, but the fact is that troponin is present. It's coming from the heart and will predict poor outcomes. These false positives are not really false positives. It just means it's not MI or ACS. So in January of 2014, my institution, Barnes-Jewish Hospital at Washington University in St. Louis, we switched our troponin I methods. And we switched from the old dimension method, which we had been using for many years, to the current contemporary architect troponin I. And these are package insert data. Limit of detections, 0.04 or 40 for the dimension, 9 or 10 for the architect, 99th percentile, 70 for the dimension, 30 for the architect, and the concentration that gives you a 10% CV was 0.14 or 140 for the dimension, 30 for the architect. And this is the precision profiles that we did when we brought the new method in, and you can see the dimension having CVs much, much higher than the architect. So the architect was far more sensitive, far more precise. And this is well known. The dimension was an older method. The architect method had much greater sensitivity, and we see 10% CVs very near the 99th percentile for the architect method. So the question we asked, now remember, this is a test where there are cut points for being above or below the 99th percentile. We, on their laboratory charts, mark them as abnormal, normal. And what was the effect of increasing our troponin method sensitivity on outcomes that were relatively easy to measure? Now, I had a resident, Craig Willen, who was an informatics geek and knew how to extract all of this data from the electronic health records and from the billing records. And just to remind you, if you suspect unstable angina, NSTEMI, some of the cut points are troponin negative, no EKG changes, or troponin positive, EKG changes. And you actually go down two different roads. If the patient is low risk, you probably do a stress test, which is non-invasive, far fewer complications. If the patient is high risk based upon a troponin above the 99th percentile, higher TIMI scores, presence of congestive heart failure, you'll go down the angiography road. Now that has some complications. Literature states around 1 to 2% have complications following angiography. So the question we asked, a more sensitive troponin assay clearly may improve diagnosis of myocardial infarction, but did it change or improve patient outcomes, patient treatments? So what is the effect of a more sensitive assay on inpatient management? So Craig went into the records of only 45,000 patients, and these were patients who had at least one troponin test performed at our institution between January 1st of 2013 and June 30th of 2014. So remember, we implemented the new method in January of 14. So we have 1 year worth of data from the old assay and 6 months of data from the new method. These were adults over the age of 18, ended up with 30,000 records from the old method, nearly 15,000 from the new method. Craig looked at the top 15 ICD-9 codes for each encounter. We looked at length of stay, in-hospital mortality. Unlike the very well-known study from Dr. Mills, they actually looked at the impact of improved sensitivity going out. They followed the patients for a much longer period of time than we did. But we looked at whether patients were given heparin, stress tests, catheterization, and Craig obtained all of that from the billing records. And then the results of the stress tests and any cardiac procedures were determined by manual chart review by two physicians. So this just shows you that the number, and this is not surprising, right? We have an improved sensitivity. But the number of patients where their first troponin method exceeded the 99th percentile went from 15% with the old method to almost 30%, 28% with the new method. So the number of patients with a value above the 99th percentile almost doubled. Those patients who had a value above the 99th percentile in any one of the first three troponins in their encounter went from 19% with the old method to 31%. Now it's interesting here that this sort of implies that we're detecting them earlier, because the change between the first value and any one of the first three is fairly small. Here it's a little bit larger. This just shows that the demographics of the patients really didn't change in the time interval, so 59%, 60% from the ED, inpatients 19%, 18%, just showing that the patient populations were extremely similar. None of these were significantly different. You wouldn't expect them to be because it's the same cohort, same institution. So what did change? Patients with an ICD-9 code of ACS went from 5.6% with the old method to 6.8%. That was statistically different. Patients with NSTEMI went from 4 to 5.3%. These are based upon ICD-9 codes. Now, this is a busy table. I'm going to summarize this with some figures following this particular slide. Demographics were not different. There was an impact on age and sex. So you'll see an odds ratio without looking at age and sex, and then you'll see an adjusted odds ratio based upon for age and sex. So let's look at some of these ICD-9 codes, and we'll just look at the odds ratios. With the new method, the odds of being diagnosed with ischemic heart disease increased twofold. NSTEMI, 12-fold. Stress tests decreased 0.7. Why is that? We have more people above the 99th percentile than below. So we're shifting from that left arm to the right arm. And here, as a figure, you'll see the adjusted odds ratios. Length of stay increased. Diagnosis of ACS. Heparin therapy increased 2.5-fold. As I said, stress tests went down, but positive stress tests went up. NSTEMI diagnosis went up almost 15-fold. The same was true in the ED. Look at the odds ratio for NSTEMI from our ED patients. So we're picking off more patients. We're treating them more frequently. So we had 14% more positive results with the more sensitive assay. Their length of stay increased. Their costs increased. You would expect that. We're now hanging on to these patients and treating them. Did more angiography, fewer stress tests, and in-hospital mortality was actually higher in that group than the group with the old. So you can imply that with the old method, some of these patients were actually being sent home. So, more sensitive troponin assays improved diagnostic accuracy and time to diagnosis. Low-level values that were previously undetectable are associated with more procedures, treating patients, not letting them go, and increase in NSTEMI diagnoses. We did not, unlike Dr. Mills, follow the long-term outcomes, but I would suspect that those patients that we identified, and this would be consistent with Dr. Mills' study from 2011, that those patients that we hung on to, treated, did better than with the old method that we did not keep and perform therapy on. So with that, I'm going to introduce Dr. Nick Mills, who will talk about rule-out strategy.
So I'm a cardiologist from Scotland, not a clinical chemist, but I've been working with my colleagues in laboratory for about 10 years now, so I've had a little bit of training. And my research is focused on how we can use cardiac troponins more effectively to improve patient care. This is the disclosure statement, and These are my relationships. The research I'm going to share with you today is funded by a research charity, the British Heart Foundation, but I am grateful to the wonderful people of Abbott, both for scientific support and for agent support in delivering some of these trials. Now, my objective this morning is to demonstrate how improvements in precision directly impact on patient outcomes. And I'm going to discuss the assays a little. I'm going to talk a little bit about diagnostic thresholds for risk assessment, and then finally how these assays are impacting on our hospitals to improve efficiencies and to make things, I think, better for patients. Now, myocardial infarction is an acute, unpredictable, life-threatening condition. Troponin is fundamental to the diagnosis, and therefore it's inevitable that the assay you use, the precision of that assay, is going to have a major impact on patient care. Now, contemporary assays have not been able to quantify troponin in healthy individuals, and therefore there's always been this uncertainty as to what the true 99th centile is, upper reference limit for use in clinical practice. And as a consequence of that, we've used diagnostic thresholds that are a little bit higher based on assay precision, or where we feel comfortable in the laboratory or in clinical practice. Here it is. But with high sensitivity assays, there's a transformational shift in the technology that allows you to quantify troponin in everyone. We can define the true 99th centile, and as such, we can be confident using the 99th centile to guide patient care and to use this as the diagnostic threshold. But does the use of lower diagnostic thresholds improve patient outcomes? We've heard a little bit how it increases the targeting of therapies, perhaps an investigation, but it doesn't make any difference to outcomes. And we looked at this question when we introduced the current contemporary assay into clinical practice. We reduced our diagnostic threshold from 200 to 50 nanograms per liter, 0.2 to 0.05. And we found that those patients with small, previously unmeasurable or undisclosed increases in cardiac troponin had a very high event rate, recurrent admissions or death. And when we simply introduced the new test and reduced the diagnostic threshold to 50, this same group of patients did better. A 50% reduction, relative risk reduction in survival. And that was due to better targeting of treatment. But even with the contemporary assay, there is critical prognostic and diagnostic information well below these thresholds we use for diagnosis. So I'd rather have a troponin concentration of 1 nanogram per liter than 30 nanograms per liter, even though I've not had an infarct with either, because I'm 25 times less likely to have an infarct at the end of 12 months. Now, using contemporary assays, we don't harness this information to make clinical decisions. And that is because of concerns about assay precision. My laboratory wouldn't let me report values below the diagnostic threshold. And the precision in the package insert is 10% at 32 nanograms per liter. Across all the laboratories in our health board, we had a 10% CV consistently around 50, and therefore that's what we elected to use in clinical practice. Now, with the high sensitivity assay, in our research laboratory, the CV is extraordinary. So it's consistently less than 10% at concentrations way below 5 nanograms per liter. If you look at routine healthcare practice, this is 33 separate NHS trusts across the United Kingdom, and we sent them a low pool value, about 3 nanograms per liter. The coefficient of variation is 12% at 3 nanograms per liter, way below the 99th centile. So what is the optimal threshold for diagnosis? The first question before we introduce this into clinical practice. And will implementation of these higher sensitive tests have a similar impact on patient outcomes? Now, the threshold for diagnosis has been made clear by the international guidelines for almost 10 years now. We should be using the 99th centile upper reference limit for diagnosis. And I think one of the most important observations with this test is that threshold differs between men and women. Women have lower troponin concentrations than men in every study that's ever been published, and the 99th centile values are twofold lower in women, 16 nanograms per liter compared to 34 nanograms per liter. Now, this isn't just with the architect, and as I say, this isn't our own work only. It's been shown on multiple occasions, and these are prototype assays or research assays. But the 99th centile in men is consistently twofold higher. Now, there are other factors that influence the reference range that might be important in clinical practice, and age is one that's often raised as a potential confounder. I personally don't think this is important, but I will explain to you why. Patients who are in their 70s or 75 years of age, this is a community cohort, do have higher 99th centile values. That reflects the presence of subclinical hypertensive and ischemic heart disease in an unselected community population. Even those without symptomatic disease, probably 1 in 5 of these patients has cardiovascular disease. And therefore, and the critical point is that those with concentrations above the conventional 99th centile value have a threefold increase in mortality. So I don't think there's any clinical rationale to set the bar higher in the elderly. I think the gender question is much more critical. Now, in introducing this test across the hospitals in Scotland, we did it as part of a step wedge cluster randomized trial. To date, we have 71,000 patients enrolled in this trial, and the question is whether lower diagnostic thresholds, improved sensitivity, will lead to better targeting of treatment for coronary heart disease and will ultimately improve survival. And one of the key decisions that the trial steering committee faced during the validation phase of this trial was whether we should report gender-specific thresholds. So in a pilot study, we asked whether there was any evidence that using a single threshold has led to underdiagnosis of myocardial infarction in women. If you look at the guidelines for help here, you find a statement which is a little vague. Sex-dependent values may be recommended with high-sensitivity tests. And as yet, they haven't provided us with clarity on this. Now, if you look at the majority of cardiovascular trials that have been published, you'd be forgiven for thinking that actually women don't have myocardial infarcts. It's mainly a condition that affects men. And the assumption here has always been that women have been understudied, right? But could this be exacerbated by underdiagnosis? And if you look at the World Health Organization statistics, men and women die from coronary heart disease at exactly the same rates. 20% in men, 21% in women. So why the discrepancy in diagnosis during life if the condition is responsible for identical mortality rates? It's also well established that women have poor survival after a myocardial infarct. And again, this has been attributed to the fact that women are often a bit older when they present, and therefore it's a factor of comorbidities. But this was a fascinating study of over 1 million Americans showing that actually the excess mortality is in younger women, not older women, and when you adjust for confounding variables, there remains a significant excess in mortality. And the fact that it impacts on younger women suggests to me that diagnostic delay or inequality in treatment is contributing to this excess risk. So we evaluated this question in 1,100 consecutive patients in our hospital. There's no recruitment bias here. We included everybody. And therefore, as a consequence, roughly half of those patients presented to our emergency department were women. And we evaluated the clinical diagnosis using the contemporary assay, which was used with a threshold of 50. In the background, we measured with the high-sensitivity assay prior to launching this commercially, and we reevaluated the diagnosis using sex-specific criteria. And what we found was that 1 in 4 men who present to hospital with chest pain are diagnosed with a heart attack using the conventional assay, and that by using the high-sensitivity test, we increased the frequency of diagnosis by a small number of percentage points. In contrast, women presenting with a suspected heart attack, we diagnose roughly 1 in 8. And if we reclassify these patients using the high-sensitivity test and using sex-specific criteria, the frequency of diagnosis increases, such that the proportion of men and women who we diagnose with myocardial infarction is identical. Now, intuitively, that feels right to me. I'm not certain why women would be coming to hospital thinking they're having a heart attack, but not having a heart attack more often than men. And if anyone can explain why that might be, I'd be delighted to hear it. So, busy slide, but there are a couple things to highlight. Women are older when they first present. It's 7-8 years in our cohort. But the risk factor profile is identical to men. And they're just as likely to have ischemia on the electrocardiogram, with the exception of STEMIs, which are more common in male smokers. But they're treated differently. So women are less likely to be referred on to our service. As a consequence, they're much less likely to get gold standard investigation. And the revascularization rates are 3-fold lower than men. That could explain differences in outcome. These differences are driven almost entirely by this group of women only identified using the high-sensitivity test and using sex-specific thresholds, who got little in the way of investigation and little in the way of treatment because they were considered low risk. But the key question, and the question that the trial aims to address, is whether reclassification of this group and diagnosis of myocardial infarction will have any impact on outcomes. Are these real myocardial infarcts that we're seeing? And if you look at survival in these patients, what you find is that if your troponin concentration in women is less than 16, you have an exceptionally good outcome. If it's identifiable, but not reported as being abnormal, using the sex-specific thresholds, there's a 1 in 5 event rate at 6 months. And if you compare those patients to those who are diagnosed with major infarcts, identifiable using the contemporary assay, and this is all patients, cardiogenic shock, then this group do worse. So I think it is likely that these patients will benefit from additional investigation and treatment, and I hope to tell you next year when the trial reports whether that is the case. So the next question that we had to address in rolling this assay out across the Scottish hospitals was, when should we measure troponin? And one of the major advantages of high-sensitivity tests is that lower thresholds allow us to detect myocardial injury earlier in the process of acute coronary syndrome. The guidelines are telling us we don't need to wait 12 hours anymore, or even 6 hours. We can make these decisions at 3 hours. Now, the guidelines in Europe are dominated by the European Society guidelines, and they now clearly recommend the use of high-sensitivity testing compared to contemporary testing, and they have algorithms like this, which I won't go into in detail, which tell us we should measure it on presentation and 3 hours later. They also have some quirky experimental pathways with 1-hour testing, which are still under discussion. In the United Kingdom, the National Institute of Clinical Health Excellence looked at the evidence behind these recommendations and concluded that high-sensitive tests should be used in the National Health Service with early rule-out pathways as an alternative to contemporary assays with conventional pathways. But they highlighted that there's some uncertainty in the evidence, that most of the studies were small, most of them were retrospective. Also, and I think this is critical, most of the studies adjudicated the diagnosis using a contemporary insensitive test, which I believe overestimates the performance of the high-sensitivity assay. And critically, I think none of them were large enough to look at what I think are the most important group of patients, those who present early to hospital. So as part of our pilot phase, before we changed the timing of our sampling, we looked at this, and we compared the sensitivity of the test at 3 hours compared to 12 hours in a consecutive series. And these ROC curves look pretty good. But actually, the key parameter is not sensitivity, it's the negative predictive value. How many patients did we miss? And the negative predictive value at 3 hours compared to 12 hours is 95%. That isn't good enough, 1 in 20 patients. So 16 out of 330 patients in the pilot phase would have had a missed infarct. Now, they had some common features. Interestingly, this is the first time this has ever happened in cardiovascular medicine. Men did worse because we have set the threshold higher for men. And you'll see that all of them have increasing troponin concentrations, but the bar is set higher in men, and for early rule-out pathways, they're disadvantaged. The other observation that's important is the vast majority of these patients presented within 2 to 3 hours of the onset of their symptoms. This is just a classic case from our trial. This is a 63-year-old woman, 2 hours of pain, smoker, family history, and you can see that her troponin concentrations were 10, 16, didn't quite meet the bar at 3 hours, but then up to 187 at 12 hours. And coronary angiography clearly demonstrates critical disease at the origin of the left anterior descending artery. Small infarct, important disease. So it's clear to us that we need a different approach to risk stratifying patients in the emergency department. The guidelines are the guidelines, but why should we use the same threshold to diagnose an infarct as to rule it out? We can measure troponin in everyone now. So we aim to define the optimal threshold that would identify patients with suspected heart attacks at presentation as low risk of myocardial infarction and potentially suitable for immediate discharge. And we did this in 5,000 consecutive patients across multiple hospitals in Scotland, and we validated that threshold in North America using an excellent cohort that was pulled together by Fred Apple and Yader Sadaval at Minneapolis. And our primary outcome was a diagnosis of myocardial infarction during that index stay, or a recurrent episode at 30, or cardiac death at 30 days. And we defined the highest concentration of troponin at presentation that would give us a negative predictive value of 99.5%. This was pre-specified and considered to give acceptable clinical risk, a less than 1 in 200 miss rate, even if you use troponin as the only variable to assess your patient's risk. And this was met at a troponin concentration of 5 nanograms per liter. So if your troponin concentration when you pitch up at the hospital is less than 5, you're not going to have an infarct. And you can be confident in discharging that patient for outpatient investigation. Now, critically, the threshold identified 2/3 of all patients as low risk, and yet our current practice is to admit or do serial testing in all of these patients. So for hospitals, this is a potentially huge impact on the way in which we triage these patients. Now, given we had more than 5,000 consecutive patients with no selection bias, we're able to evaluate the performance of this threshold of 5 across key subgroups. So everyone's worried about sending someone who's known to have heart disease home, who's got chest pain. The negative predictive value is identical, irrespective of whether you're known to have coronary heart disease or not. You don't have active coronary disease if your value is below 5 when you present. Now, the only subgroup where there was any heterogeneity in this trial was those that presented early. So if you had chest pain for less than 2 hours, even at a threshold of 5, the negative predictive value drops to 98%. Still pretty good, but we'd recommend retesting in that group. Now, we've been comfortable for a long time sending people home who've got normal troponins, below the diagnostic threshold, below the 99th centile. But the truth is, there's risk in that group too, but not at less than 5. And if you take the 3,500 patients who we ruled out myocardial infarction, the outcome at 1 year, the event rate at 1 year in those that are less than 5 was less than 0.5%. This is not a group to spend a lot of time doing stress tests and investigations on. They're extremely low risk. You're much better off concentrating your efforts on this intermediate risk group that don't have an infarct. So we've now incorporated risk stratification thresholds, delta change criteria, sex-specific diagnostic thresholds into routine care across the hospitals in Scotland. And this is the pathway that we use, and we're evaluating the safety and the efficacy of this pathway in clinical practice. Critically, we make a decision in 95% of patients in the ED. We either rule out an infarct or we make the diagnosis. Only 5%, 1 in 20 patients, require hospital admission for further investigation to clarify that diagnosis. And we've compared the negative predictive value of this, what I would call optimized pathway, to a conventional ESC guideline pathway based exclusively on the 99th centile. And the negative predictive value is consistently higher in the optimized pathway. And that is true for the early onset group as well as those with established ischemic heart disease. So in finishing, my conclusions I think are consistent with national guidelines in the UK, where high sensitivity tests are approved for clinical use. Rapid assessment with using innovative thresholds and retesting at 3 hours is a reasonable alternative to a contemporary assay where you bring the patient in and do multiple tests over 12 hours. And they have major advantages, I think, for hospitals in terms of efficiency and for patients in terms of giving them clarity of diagnosis. One physician, one diagnosis, not multiple physicians and multiple opinions. And the other recommendation that we made is that we should use different criteria for diagnosis of myocardial infarction in men and women, and I think that is clear. And the only note of caution is that even with high-sensitive assays, we need to take extra care in risk assessing patients who present early after the onset of their symptoms. So I'll finish just by thanking all the wonderful people that did the work and Abbott for their support and for your attention. Thank you.
My name is Peter McCullough, and I'm an internist and cardiologist at Baylor in Dallas, and it's a really distinct honor to come to the AACC as a cardiologist and get a sense of all the excitement in laboratory medicine, and many thanks to Abbott Laboratories, our sponsor today. I'm nearly certain I've fixed the problem on the computer now, so we'll have a smooth final session, and I'm going to present on galectin-3, a step towards a clearer pathway in heart failure management. And this is, compared to troponin, this is a much newer assay that's been made available, certainly in the United States in the last several years, and actually been on laboratory platforms now for just under a year in U.S. laboratories. Galectin-3 has actually created a lot of excitement and has relatively quickly gotten into our guidelines now. It's highly recommended that in our initial consultation of patients with heart failure and then in management, that this test be utilized because it's the first test that we have in cardiology of a factor that's directly pathogenic in heart failure. Remember that BNP and troponin themselves are not pathogenic. They're a reflection of myocardial disease, but galectin-3 is actually a pathogenic factor that we can measure and certainly help us understand what's going on with patients. So I have a brief presentation, and after this, all the speakers will come up into a panel, but just want to make a few points. One is regarding heart failure, and just to have the laboratory directors in the room become sensitized to the idea that heart failure is the leading cause of adult admission to hospitals in developed countries. Once diagnosed with heart failure, most patients will have continued exacerbations and hospitalizations for heart failure. It's the most frequent diagnosis associated with a 30-day readmission now. In U.S. hospitals, that carries with it a penalty from CMS in terms of our overall reimbursement. The current national average in the United States for a readmission is 23% at 30 days. And we really have to carefully manage patients in order to skillfully guide them into ambulatory care. So each time a patient has an exacerbation, in general, they've taken a further decline in terms of their overall quality of life. We can't prevent all the hospitalizations, but many believe at least half of these recurrent hospitalizations are avoidable. Now, I mentioned galectin-3 being part of the pathogenesis. I think it's important to understand that in the setting of heart failure, no matter what etiology, there is, in a sense, a dropout and dysfunction of normal cardiomyocytes and a replacement with cardiac fibrosis. And fibrosis of the heart, just like there's fibrosis in the skin and fibrosis in other organs, is a manifestation of both aging as well as chronic disease. All of our manifestations of heart failure that we see on echocardiography in terms of left ventricular systolic and diastolic dysfunction, arrhythmias, heart block, all of these things are manifestations of cardiac fibrosis. And what we understand is that, as you can see here, cardiac fibrosis leads to left ventricular stiffness, which leads to what's called dyssynchrony or disorganized contraction and reduced pumping power, but also tissue heterogeneity and isotropy and actually the genesis of arrhythmia. So the reason why patients need defibrillators is because of cardiac fibrosis, whether that scar has been caused by an acute infarction or whether or not that's developed over time, even in non-ischemic cardiomyopathy. Fibrosis also occurs in the vasculature, and it's related to impairment of function of the heart during diastole, or the rest cycle of the heart. And the bottom line is patients with heart failure have a very high cause-specific mortality. Now, in the largest study of heart failure I published now about 15 years ago, the REACH study, we found that 90% of heart failure deaths were due to heart failure itself. The most current estimates now is probably about 60%, meaning that if a patient has heart failure, there's a 60% chance they will actually directly die of heart failure, and the two major modes of death are either pump failure or sudden arrhythmic death. Now, what is galectin-3? Galectin-3 is measured in serum or plasma, so it's a measurable factor. Well, it's one of a family of what's called animal lectins. It's a glycoprotein. Its gene is known and sequenced. It's the most upregulated fibrosis-related protein in the myocardium of the failing heart. It's secreted by the satellite cells in the heart, macrophages, neutrophils, cardiomyocytes to some extent themselves. It's primarily a paracrine autocrine signal. It's rapidly internalized by cell surface beta integrins. It can form pentamers at the cell surface and activate growth factors. Its main target is secreted by macrophages, but its main target is myofibroblasts. And via intracellular signaling, it translates the TGF-beta signal for rapid cell cycle upregulation. So these myofibroblasts proliferate, and they lay down procollagen-1, which is cross-linked to mature collagen, and that's how fibrosis occurs. The same process, by the way, occurs in your skin. If you've ever cut yourself in your skin, you wonder how do those skin edges approximate, and how does this scar form? The skin it becomes relatively quickly loaded with macrophages that start producing galectins, and those galectins direct the fibroblasts to lay down the fibrin. That's how scarring occurs. Galectin-3 is known to be pathogenic. It induces fibrosis in animal models, which I'll show you. And it has a natural inhibitor, by the way, called ACSDKP, and it's analogous to plant pectins. And so there's a tremendous work right now on therapies that are anti-galectin therapies, both in heart failure, kidney disease. There are anti-galectin therapies, believe it or not, for skin disease and aging. So there's a tremendous interest in this factor, which is part of a family of animal lectins that is on the side of fibrosis and healing in the human body. In cardiac remodeling, we use the term remodeling, meaning adverse morphologic changes in the heart. We know in the setting of myocardial injury, it can trigger inflammatory and wound healing responses. In Baylor, we study this in the lab, in our pathology lab all the time, and we know that even half or more of myocardial tissue within a few days of a myocardial infarction can be loaded with granulocytes. Macrophages get turned on, they secrete galectin-3. That galectin-3 is released by the macrophages. It binds and activates the myofibroblasts, and the myofibroblasts begin to lay down collagen, and in fact we develop fibrosis. And in fact, in settings of myocardial infarction, we can see 75% or more of wall thickness is actually thinned and fibrotic tissue, but also in forms of non-ischemic cardiomyopathy. I'm always amazed when we do histopathology how much of the myocardium is actually collagen and fibrous material. We use the collagen stains all the time. Well, in the published studies, in the population-based studies, what was learned early on is just in apparently healthy individuals followed over time that the galectin-3 level measured in plasma was related to all-cause mortality. And these data come from the PREVENT study in Groningen, the Netherlands, and so just organized by Quantile, suggesting that galectin-3 must have some relationship to overall survival or perhaps advanced biologic senescence. And then there was a whole series of studies through a whole variety of clinical settings. In this case, in patients after acute coronary syndrome, where the galectin level was clearly related to the development of heart failure. Now keep in mind, galectin doesn't change very rapidly. So it doesn't change in the setting of a myocardial infarction. So the belief here is these galectin levels, these are measured on admission. This is the level that people had coming into the myocardial infarction. So if a level was greater than 19, as an example, nanograms per ml, that the patient who had a myocardial infarction on top of this higher ambient level had a much higher risk of developing heart failure. It's been shown through a whole variety of elegant studies that galectin-3 does mark the activation of macrophages in hypertrophied hearts and directly contributes to myocardial dysfunction. And in studies where the genes have been manipulated, when we can upregulate the development of galectin-3, there's no doubt about it that patients, in this case, the rats were patients in this experiment, developed heart failure. And the heart failure is related to a marked increase in collagen content in the myocardium, and one can get to a certain level of galectin-3 and collagen content where predictably left ventricular ejection fraction drops. There's simply enough replacement of cardiomyocytes as well as infiltration of fibrosis where the heart cannot contract normally. It's been shown in humans that galectin-3 is related to the amount of fibrosis we can assess by MRI. Now, MRI is still an evolving technology. We can't see fibrosis to the level that we can see it in the pathology laboratory. But what you need to know here is certainly above and below a cut point that there was a higher percent overall size of the fibrotic scar after myocardial infarction by MRI in humans. And it's been shown in a whole variety of studies that compared to controls, if we have wild type and we have knockout galectin-3 models, that when we expose animal models to angiotensin II or to transaortic constriction, these are both models of developing hypertrophy and heart failure, that if we knock out galectin-3, we markedly attenuate the fibrotic response in the myocardium. So this whole series of deductive arguments suggests that galectin-3 is directly pathogenic in the development of heart failure in animal and translational models. Epidemiologic evidence suggested it's related to all-cause mortality. So it's kind of had a biologic plausibility that, in fact, the test could be used in human populations. And so we've published on this to try to get a set in a normal population, what is this age-related range of galectin-3s that we can see in individuals? And the answer is, it probably centers on about 11 nanograms per ml. So this test does not have a set cut point. It's not like troponin, where it's been put through the rigor of lots of normal populations. So there is a general understanding that a normal galectin-3 level is about 11, in that the various manufacturers of the assays typically give a median value or a risk value. Some of the assays use 17.9, another assay uses 22, just simply as a median to tell you that that's sufficiently elevated that risk exists for prognosis and heart failure. So what do we know about prognosis? So galectin has an FDA clearance as a prognostic aid in patients with heart failure. So this is on top of everything that we know in heart failure. It's not a diagnostic aid and it's not a screening test, but it's a prognostic aid. And to the extent that there is a linkage between prognosis and management, that's how we understand contextually how galectin-3 fits into our care of patients with heart failure. What you need to know is that in the Framingham Heart Study and other really high-quality data sets, no doubt about it, that galectin-3 in apparently healthy, normal, middle-aged individuals predicts the development of heart failure. Far and away, as you can see here, you can see the clustering. Remember I said 11 from the PREVENT study. Well, in Framingham, it's somewhere, normal is somewhere down here, but as we get to levels over 15, there was no doubt about it, there was a striking difference in the development of heart failure. All these patients were very, very assiduously assessed at baseline. They had echocardiograms, baseline tests. They did not have heart failure. And over the next 10 years, galectin-3 clearly, there's no other test that I'm aware of. BNP wasn't able to do this. There was no other echocardiography. There was no other test in Framingham or any other data set that was able to predict the development of heart failure from a normal population. This has been supported now by the Physicians' Health Study, another normal population, where you can see here galectin-3 levels in the highest quartile. In this study, it's centered on 13.7, pretty close to Framingham. Here there was, in the adjusted models, there was about a 60% excess risk for the development of heart failure in apparently normal, healthy physicians. So I think galectin-3 can be well positioned based on the science as a test potentially that we would use in the risk prediction for the development of heart failure. We have anticipatory therapies, by the way, for heart failure that can prevent the development of that condition, and that's been shown in a whole variety of studies, and they include renin-angiotensin system inhibitors as well as beta blockers. Now, among those with heart failure, it's been well shown in this NIH study as an example that once we get in a heart failure population and now the galectin-3 levels are way above the concentrations that I've presented so far, we can see a progressive increase in risk for cardiovascular mortality. So greater than 25, all experts agree there's more than a twofold increase for cardiovascular mortality among patients who are otherwise very well understood from a clinical and imaging perspective. Galectin-3 does also anticipate the risk of heart failure hospitalization. This is a prospective study of some pretty well-treated patients with heart failure, and those individuals below 17 had about a 5% overall 4-month risk of hospitalization compared to 15%. So even in ambulatory patients in the office, our snapshot of where patients are from a galectin-3 can clearly separate risk for heart failure hospitalization. And this is a paper I published a few years back demonstrating that if we were to look at these events over time, once we get greater than 25, there's a higher risk of death than even hospitalization. So these patients have very advanced disease, and compared to the lowest overall concentrations here, it's possible for a fraction of patients, about 25% of patients, to have galectin-3 levels that settle down below 15. Those patients have the overall lowest amount of risk as followed over several years of time. Now, people have asked the question, can galectin-3 levels change with therapy? And the answer is very little. Only we can see changes of about 15% in concentration. So once patients have a galectin-3 level, they seem to be relatively set at that level. It's clear if patients stay low, that the overall prognosis is more favorable, and this is from a large randomized trial. Going from high to lower is better than going from high to high or low to high, and there is some separation in these event curves, even though the events are relatively frequent in all the groups. What you need to know is galectin-3 is not a frequent laboratory test, so it's not something we're measuring every day, or we're not measuring several times on admission. It would be a test, in my view, that we'd probably measure no more frequently than every 6 months in the office. Now, there are complementary data with the natriuretic peptides, and it has been studied, for instance, with N-terminal proBNP. If we look at galectin-3 and N-terminal proBNP and their elevations in a chronic heart failure population, what's been shown is that galectin-3 does help reclassify patients when those are stratified above and below the median. These are picomoles per liter, so these are a little different than what you're used to seeing in your U.S. laboratories. And that galectin-3 is complementary to the measurement of natriuretic peptides in terms of predicting, in this case, mortality. And all the studies show this. It's not a replacement for BNP, nor does BNP replace the knowledge that you get with galectin-3. The two are complementary, and that's the reason why the guidelines in the United States, the American Heart Association guidelines, suggest that practitioners measure both a BNP or a natriuretic peptide and galectin-3. Here's another way to look at it, just showing the complementary nature, and these are just cut above and below the median. So clinicians can actually use these tests to better anticipate risk of mortality and heart failure hospitalization. And how can that potentially translate to an improvement in management? Well, the problem is the heart failure population is so large. It's the leading cause of hospitalization. There's not enough cardiologists in the world to care for our heart failure patients, so we have a large contingent of patients managed by primary care physicians and hospitalists. And in fact, galectin-3 is probably mediating and driving heart failure in this population where it's elevated compared to those where it's not. So if we could actually understand, and this two hypothetical patients. Here's a patient at low levels. Remember, 25% of patients with heart failure can actually have galectin-3 kind of managed in this normal range. They have terrific outcomes. And I've had patients certainly as high as this, and they look just exactly like this. They have a rapid decline. So the test can help us better, I think, stratify and understand where patients are. And particularly in many of these studies, it's additive to everything that we know, including renal function, anemia, presence of diabetes, imaging. It's strongly independent of all of these factors in terms of anticipating risk. And this is it's very externally consistent across a whole variety of populations. In this case, a paper from Spain. So how can we actually effectuate this and put it into practice? And so we've had a lot of collaborations across the world, and we measure it. I measure it virtually every day in the office at Baylor. So when I have to get back, actually after this, get back to the hospital, we'll probably end up measuring it before the end of today in a patient. In my view, galectin-3 measured in blood has been shown to identify increased risk for new onset heart failure. That's Framingham Physicians Health Study. It predicts heart failure in patients after acute coronary syndromes. It helps establish the diagnosis of heart failure with preserved ejection fraction in patients presenting with exercise intolerance. Didn't show you the data there, but I think that's probably one of its plays in terms of diagnosis. And then it certainly aids in the prognosis of heart failure with preserved or reduced ejection fraction. So in 2011, we proposed this algorithm and has followed it, and others have published on this concept that if we have a stable patient, and galectin-3 is largely an office ambulatory test where they have confirmed heart failure and they stratify out as low risk, our practice is to have usual care and follow-up in my office. That's probably seeing the patient about once every 3 months, and we don't change their medical therapy. Patients who fall in this intermediate zone, we certainly counsel them with respect to risk, and we start to intensify the medical management. In heart failure, we have 12 interventions that reduce heart failure hospitalizations and death. We can't increase all 12 things in all patients, but we start to intensify in this zone here. And then greater than 25, my experience is these patients are absolutely high risk. All the data suggests that we intensify their medical management. We see these patients at least once a month. We start implementing advanced strategies, in this case, start putting our nursing resources behind these patients. And we reassess probably as early as 3 months. I think 6 months is probably more appropriate. If we get a drop in galectin-3, a 15% reduction, we know they've improved. A 15% increase, we know despite our efforts that things have worsened. But this is a real helpful guide as an objective blood test. In my view, even blood BNP hasn't allowed us to do this in the office. We know echocardiogram won't do it, angiography won't do it. We know the stethoscope hasn't been doing it, and the clinical evaluation, because our admission rates are so high. I think we need some technology, and my personal view is I think galectin-3 is the right technology for ambulatory heart failure patients. So to finish and conclude, galectin-3 is a measurable key mediator in the pathogenesis of myocardial fibrosis, a fundamental mechanism of disease progression in heart failure. Its elevation of those levels in the general population in patients post-MI is associated with the future risk of heart failure. In these patients, we can intercede with preventive therapies. Irrespective of ejection fraction, the elevated galectin-3 levels indicate increased risk for mortality and heart failure rehospitalization. It's an independent and complementary to natriuretic peptides as they measure distinct different biological processes, and they aid together in our prognostication of patients. And given the very high rate of short-term events in heart failure patients with elevations in galectin-3, in my view, patients with high levels over 25 really should be considered for advanced therapy. So I'm going to stop here. I'm going to invite Mitch and Nick up for a panel discussion. And again, how much time do we have? Are we good? Okay, so come on up, you guys. We'll have a panel discussion, and we'll ask for your questions. If you come up to the microphone and just identify yourself and your institution, and we'll answer them the best we can.
So I'm really interested in galectin-3. We don't measure it, but we have it available. For me, Slightly obsessed with understanding the mechanism of heart failure. Why has my patient developed heart failure? And I guess the area you didn't touch on is whether it helps you to identify those patients that need more advanced imaging, cardiac MRI, differentiate between those with gene-mediated hypertrophic cardiomyopathies or aggressive diastolic heart failure syndromes. Is there a role for identifying patients who need further mechanistic investigation?
Yeah, I think the one area you hit on that's important is what Nick termed as aggressive diastolic dysfunction. And there are data suggest that galectin-3 really helps identify that patient specifically. There aren't great data, by the way, for hypertrophic cardiomyopathy or sarcoidosis or some of these others. But for diastolic dysfunction, and so for those of you in the room, there are two types of heart failure, systolic and diastolic dysfunction. Systolic dysfunction, we have 12 proven therapies, and we have a lot of successful trials. In diastolic dysfunction, we don't have a single proven therapy, and we have a lot of frustration, and that's 50% of the population. And it's very hard to dissect out patients who are just simply overweight and deconditioned versus those who have diastolic dysfunction. So I personally find the test really useful. Oh, here we go. So ACE inhibitors and ARBs and beta blockers and nitrates and hydralazine and ivradabine and sacubitril and digoxin and biventricular pacing and ICDs, and I think there's two more out there. I mean, the thing is, we can't apply everything to all patients in heart failure. We have to stylize. One of our clinical trials right now going on is actually to use that. There are actually 4 guidelines recommended biomarkers in heart failure. So it's, believe it or not, it's troponin and natriuretic peptide, galectin-3, and ST2. We measure all of them in a prospective study, and we actually stylize our therapy towards responding to these markers in a response plane.
Yeah. My question is twofold. For Dr. Scott, we saw a lot of data from Dr. Mills that ruling out with the 99th percentile, especially with high sensitivity assays, is probably not optimal. Using the same threshold for diagnosing and ruling out probably ends up in missing a lot of MIs. Was any of that reviewed in the data that you ran, even with the contemporary or the contemporary sensitive troponin assays?
No, because we only had the one cut point, which is at the 99th percentile. So with the contemporary assay, the lowest value we report is the 99th percentile. So we couldn't look at, so 0.03 or 30 is the lowest we report. So we couldn't look at what would happen if we reported a 5 or a 10, because quite frankly, the contemporary assay doesn't go that low with sufficient imprecision.
And for Dr. Mills, were you able to compare the less than 5 threshold to, say, the contemporary assay rule-out strategies? I know you did the high sense versus the low threshold.
Yeah, that's an interesting suggestion. So we have the data. We haven't looked at it. I mean, the contemporary assay does give values down to those levels. It's just the confidence around using those values in clinical practice that we don't have with the contemporary assay. But we could certainly do a comparison, and that might help to inform how people use the contemporary assay slightly differently. But my guess is that most institutions that report with a contemporary assay don't even disclose the values below the diagnostic threshold. So we're blind to all that rich prognostic information when using a contemporary assay with a threshold. And actually the main impact of switching to the high sensitivity assay was we suddenly reported these absolute values and we had to start thinking about them. And that was really eye-opening. Troponin had always been a binary test. It's an infarct or it's not an infarct. But now it's a prognostic test as well as a diagnostic test wrapped into one. And it really is starting to change the way we approach patients and we select them for investigation.
So Nick, I had a question for you exactly on that topic. There have been some analyses suggesting that when you use the high sensitivity assays, that in fact unstable angina is going away as a diagnosis, that we always used to have patients with no MI, unstable angina, and myocardial infarction, in those three categories. And I thought I saw this in your data, that if someone has serious enough chest pain to come to the hospital, it looks like they either have an MI or they don't have an MI. There's really no more unstable angina.
Yeah. Well, unstable angina is a classification that's been around since Eugene Braunwald put it forward, 20, 30 years ago. It's the same underlying pathology, unstable angina and myocardial infarction. The pathology is the same. We've just had limited diagnostic tests for acute coronary syndrome for many years. Now we have a test that allows you to not miss any degree of plaque rupture, because microembolization from a small plaque rupture leads to injury. And therefore, we adjudicate unstable angina in our cohort of 70,000 patients. It's an adjudicated diagnosis in about 1% of patients now. It used to be 10%, 20%, different hospitals. It's 1% now. And even in those 1%, I'm not sure, because almost 90% of those patients have got a previous diagnosis of coronary heart disease. They come in with chest pain at rest, and it's hard to say it's not unstable angina. But the truth is they don't have myocardial injury. They probably don't have an unstable plaque. They just have angina.
Well, you really got me worried, because last night about 9 o'clock I got called from a patient who has coronary disease, and she was having more chest pain, and I prescribed some nitroglycerin. I called Walgreens and I prescribed nitroglycerin, which was the traditional time-honored thing that a cardiologist does, is to have patients use nitro for chest pain. But it does make me wonder if even stable angina, if these little bouts, in fact, are they little microinfarctions?
Well, I think the reason it's such a powerful prognostic test is partly because it is identifying subclinical active coronary disease. Coronary disease is not simple. We like it to be stable, unstable, little boxes. This is a dynamic condition. It progresses over many, many years with periods of disease activity and quiescence. And what troponin is telling us in patients with coronary heart disease is the activity of the coronary plaque. And therefore, there are patients who are high risk with no apparent symptoms. And I think in the future, we're going to use this test out with diagnosis for myocardial infarction, but in tailoring and risk stratifying patients who we know have coronary heart disease better. And I think probably the first development we're going to make is who to intensify statin and lipid-lowering therapy in, and how long to give dual antiplatelet therapy following a plaque rupture, and when we can safely withdraw treatments that are no longer necessary. And I think that's one of the areas that it will have a role on in the future.
Hans Schneider, Melbourne. I liked your data on women, Dr. Mills. As I'm getting older, I'm seeing more and more older women in hospital. I work as a generalist in a hospital that are in their 80s and in their 90s. And chest pain is not the predominant way that they present. They present with a low blood pressure, with a bit of shortness of breath. They've got diabetes. They've got lots of other comorbidities. Yeah. And I wonder, in your studies, have you included those patients, or are you primarily concentrating on patients with chest pain?
This is a really important point. Most studies that have evaluated troponin in acute coronary syndrome have approached and consented patients with chest pain. And therefore, this group, predominantly women, as you say, and elderly individuals, have never been included in the trial populations. Our approach is that we want to understand how the test is used in clinical practice, and therefore we randomize hospitals, not patients. We include everyone, and the clinician identifies the patient for enrollment in our trial at the time that they order the test. So if the clinician orders the test and they tick a box saying suspected acute coronary syndrome, they're in the trial. So 80% have chest pain, 20% do not, but we do capture those suspected acute coronary syndrome without chest pain, the less typical patients in the trial population, so they are in there, which is unusual in most studies.
So thank you all for excellent presentations. I'm just curious, the 5 nanogram per limit rule out, I think that's the limit of detection, is that correct?
The limit of detection is 1.2 nanograms per liter, so it's fivefold above the limit of detection.
It is very low. And then the 99th percentile is around 15 to 20, is that right?
At 16 for women, 34 for men.
So what about in between the limited detection and the 99th percentile? What do you do with those patients?
So this is really an interesting question. Right now, they're flagged up in our pathway as amber or orange and intermediate risk, and we recommend a retest there. If there's a change, and the delta criteria that we've optimized is 3, so if it's less than 3 on retesting them, then that is chronic and stable. If it's changing, then we recommend you admit them because they're intermediate risk, and this is the group of patients you might consider for stress testing, CT coronary angiography. They don't have an infarct, but they're intermediate risk. Now, I grant you, some of them will be elderly patients with hypertensive heart disease and won't necessarily need treatment for coronary disease, but they may benefit from seeing a cardiologist and for optimization of their risk. So I think as a triage tool, a risk stratification tool, it's really powerful. But there's a lot of education involved and a lot more research as well, I think, in understanding what the optimal investigations and treatments are for that intermediate risk group. So that's still an emerging area of research, I would say.
Good morning. Thank you for your presentations. Ludwig Albornoz from Cali, Colombia. I mentioned my home city because I come from a third world country. In an effort to transfer the 99th percentile from the first world to the third world, we were in the effort of transferring reference values. And our findings are that they are quite different. We're using healthy, quote unquote, healthy donors from the blood bank, local blood bank, our own. And the difference is quite striking. Therefore, since at least the package inserts do not specify very clearly what is the ancestry of the patients or the normal population studied, I wonder if there may be even a bias, but a positive bias in the sense that our donors might have a subclinical, may not have that subclinical coronary disease that is present in the general population, and therefore we need to look at things differently locally. Any thoughts on that?
Yeah, key question, how do you define normal? Really what you want to know is what the threshold should be for diagnosis in the population you're testing, and people do have subclinical coronary disease out there, and therefore I think coning the population that you define the normal reference range in so tight that you have a very, very low 99th percentile is not helpful. But it's true that different healthy populations across the world will have different distributions. In Southeast Asia, the 99th percentiles tend to be a little bit lower than in Caucasian and other populations. It used to be that the recommendation was you performed your own normal reference range study and used those limits. I don't think that's valid anymore. There are so many large population studies out there that I don't think it's necessary to do that. And I think that the package insert 99s are broadly applicable, but maybe Akeem wants to add to that.
Thank you.
I just want to make a comment. Nick, I was curious to see that in this big population, if you were less than 5 nanograms per ml, basically with a single troponin, you had a high enough negative predictive value, and that population was 70% of that universe of patients presenting with chest pain. That's exactly what we found with the original trials of using CT angiography acutely in patients with chest pain. We found that 70% of individuals who, if they came in with chest pain, they had no prior history of coronary disease and no ischemic changes on EKG, that 70% of that population would have stone-cold normal coronary arteries. So what the ER directors need is they need a tool to let them quickly get to normal and basically negligible risk and send home. And I think that's the greatest hope of these ultrasensitive troponins, is the negative predictive value at that low end. I mean, that's the winner. That gets rid of 70% of the population almost upon arrival to the ER. That's how powerful it can be.
Yeah, agreed.
Before I ask my question, and I think we'll have time for at least a couple more questions after this, let me just make a quick announcement. We would highly appreciate if everyone could fill out the evaluation forms. I want to thank the speakers. It was a phenomenal presentation and workshop. My question is really around what Dr. McCullough sort of alluded to with galectin-3 and the natriuretic peptides, is that the modification, although it might be small, is indicative of improvement. And it does have additional prognostic value. For Dr. Scott and Dr. Mills and maybe even Dr. McCullough, do you see that, or have you seen that in data or in studies or in your own work around the troponins or the high sensitivity troponins?
Well, I'd like to emphasize something that Peter said. He looked at changes in galectin-3 and suggested that a change of 15% rise or 15% fall was predictive of bad or good outcome. And he also stated that galectin-3 is very stable in patients. It doesn't change much. And I would just want to confirm that with a study that we did, published in ClinChem earlier this year, where we looked at 60 patients with stable heart failure. And for galectin-3, the within individual variability was less than 5%. So a change of 15% truly is a change. That contrasts to BNP, the same 60 patients, where the within individual variability was 30 to 35%. So the fact that the within individual variability of galectin-3 is so small really enhances its predictive value when you see relatively minor changes. I mean, if you hear 15%, you think, well, 15% is really not that much, but it is.
Yeah, I'd agree with that. I think the only mistake you can make with galectin-3 is having people start to order it too frequently. It doesn't change that dynamically like BNP. So our response to BNP most of the time is actually a change in diuretics because patients are probably getting too high in terms of their overall volume and left ventricular wall tension. Our responses to galectin-3 are mainly on the initial consultation to understand prognosis. Now, there are several studies showing that the inhibitors of the renin-angiotensin system, target this problem of fibrosis, and specifically mineralocorticoid receptor antagonists. And there's one trial from Romania that's shown that, in fact, use of spironolactone or a similar drug called eplerenone actually drops an entire profile of profibrotic peptides, including procollagen 1 and these other factors. That's still very preliminary, but some doctors are saying high galectin-3 patients are really those that we should push harder for the mineralocorticoid receptor antagonists, which are only used in about 40% of patients right now.
I don't have any experience with looking at change in galectin, but we are starting to look at change in troponin as a modifiable risk factor in coronary heart disease. And there's emerging evidence, a lot of it's unpublished, showing that your troponin concentrations can be reduced by therapy, particularly statin therapy, and that change in troponin concentration over a period of time is an independent predictor of future risk over and above your baseline concentrations, plus all the premium risk factors. So it's a dynamic marker of disease activity that we can modify with therapies that we know improve outcome, and lower cardiac troponin concentrations are associated with lower future risk. So I think it will not necessarily replace monitoring lipids with time in response to therapies, but it will certainly be an important adjunct.
Do you use an absolute or a percent change? Where are you looking?
Yes, so a lot of the research is done in aggregates in large cohorts. We use the WASCOPS trial, randomized trial of pravastatin. How you use that in individual patients is uncertain. We need prospective studies where we change our treatment modality in individual patients. But yeah, the value that predicts increased risk in patients without coronary heart disease is 5. So if you're above 5, you're at increased risk. If you're below 5, you are not at increased risk. And so my guess is we'll start targeting people with statin therapies above 5 to try and get them below that level.
Any final questions? If not, we all thank you.
Very good. Great work. You're doing a great job. Congratulations.